că da.
Doamna doctor Monica Monica, aveți cuvântul. Vă rog.
Mulțumesc frumos. Prezentarea am gândit-o în engleză, fiind o manifestare internațională. Sper să fie în regulă pentru toată lumea. Honored audience.
Am dezactivat și microfon.
My name is Monica Morcăș. I am PhD student at Transylvania University Brașov in palliative care medicine under the supervision of Professor.
Iau fi dragă, român că prezintă lucrarea în engleză.
I shall talk to you about artificial intelligence for pain assessment in
Doamna doctor, să știți că nu vă auzim. Puteți să porniți microfonul? Doamna doctor Marcas. Doamna doctor, auziți? Așa. Cred că, așa, de pe Teams. Intrați pe Teams. Teams. Așa. Nu. Exact. Și așa, perfect.
Nu știu cum am reușit să mi-l dezactivez.
Da, să opri. Nu e problemă. Puteți acum să vă întoarceți la prezentare. Așa. Full screen.
Și full screen, da. E ok acum?
Da. Restul, vă rog să
Chronic pain, on the other hand, is a disease itself, given the dimension, the total dimension of pain that is involved in the biopsychosocial model, coming with a decrease in quality of life of patients, but also with a burden on the carer and families. Our vulnerable populations cannot communicate the presence of pain. Who are these vulnerable populations? We are talking about the age extremes, therefore infants, children, and elderly people, especially the ones that also develop cognitive dysfunctions. In the last decades, there has been intense research regarding pain biomarkers, imaging markers of pain, and clinical data analysis. We are dealing with a lot of data we need to examine, and that's where computers are helping us. There have been developed computational models in order to analyze these large sets of data for predictive models regarding the etiology of pain, the probability of developing certain disorders, and also the response to pain treatment. The artificial intelligence-powered tools assist us also with the routine tasks. The most important aspect of them is the reduction of time and resources necessary for data entry, visual inspection. There are a myriad of methods of artificial intelligence that found their utility also in medicine. Ever since around the 90s, machine learning was one of the first methods that were widely used. It is a sort of umbrella. This method is a mathematical algorithm that helps us analyze large sets of data and develop models that will predict or cluster those data. It can be divided in certain subcategories. The mostly widely used are the unsupervised learning, in which data are not labeled the supervised learning in which we have the data labeled and therefore superior predictive value. In reinforcement learning, the algorithm itself can learn from its own errors. It's like a trial and error.
Nu vă mai auzim, aveți microfonul închis. Dacă puteți să deschideți din nou.
Mulțumesc. Again, who are our vulnerable patients who can experience pain but in a silent mode? We are talking about our elderlies and our infants and children. I didn't have to worry about data protections of the GDPR regarding these images because they are generated with artificial intelligence, but quite credible, we can say. Let's see what we can do for our patients with neurocognitive disorders. It has been shown that there is no difference in pain between dementia subtypes, but the more severe the neurocognitive problem, the more pain our patients express, and unfortunately, the less they are capable of telling us. There is a equivocal relationship between pain and neuropsychiatric symptoms. On one hand, the same symptoms may appear due to pain or due to the illness itself, like agitation, depression, sleep disturbances. But untreated pain may also be a trigger for a worsening of these symptoms. People with dementia cannot easily express their suffering because on one hand there is the speech impairment, but also they have the memory issues. They sometimes effectively forget the experience of pain. We cannot always believe what they're telling us when it comes to intensity of pain, for instance, and it is difficult for them to evaluate the effectiveness of treatment, and for us as well to assess this evolution. Pain assessment has to rely on the observation of a caregiver or health care professional. We are using visual auditory cues such as facial expression, vocalizations, or body languages. It is almost impossible to see whether a person is in pain or not. Especially in patients with chronic pain, where the phenomenon of habituation and masking appear. It's a strong evidence that facial expressions indicate pain in people with dementia. There has been developed in around 1978 the system of face action units in which certain facial expressions are associated with certain emotions. We well know the pain has this psycho-emotional dimension and will influence our pain expressions. Pain indicative expressions in people with dementia have seemed to be brow lowering, cheek raise or lid tightening, nose wrinkle, opening of the mouth. These being able to differentiate between painful and non-painful conditions in this category of patients. There has already been developed and validated an automated assessment system for pain in the elderly. The application, because it is a software, is called Pain Check. It can be used on different smart devices like smartphones or tablets. It uses artificial intelligence and facial recognition technology to identify facial expressions of pain. It simply uses the inbuilt camera of the device and detects 9 pain-associated facial expressions in a binary mode. Therefore, 0 means it is absent, 1 means it is present. Based on the 3-second video facial analysis, the Pain Check will report a score and also store the results. Of course, this has been validated in clinical trials. For instance, last year, Pu et colleagues have performed a study on 46 residents in a nursing unit, proving the association between facial expressions and observational pain score were independent of factors that may impact the perception and behaviors of pain, like age, gender, cultural background, the medication patients were receiving, and also the cognitive function. As expected and proven in other studies, female residents had a significantly higher pain score. There have been developed also other pain scale that use also artificial intelligence and do not require the self-assessment of pain, like Mobit pain scale that is based on guided movements of the trunk and extremities, focusing on the appearance of nociceptive pain during these movements. There are 5 types of active movements. The patient is instructed by a healthcare professional, which will immediately stop the movement if a pain behavior appears. Movements are to be performed on one side at a time. Special attention is directed towards observing pain behavior in order to be able to have a score of pain intensity. And the main behaviors that are registered are vocalizations of pain noises, facial expressions, and defense. The patient is recording with a mobile and static camera, and it is zoomed in important sequences of movements or facial expressions. It has been proved by Husebo and his team even since 2009 that even in patients with severe dementia, it is a reliable scale in order to have the correct intensity of pain. We also have other types of devices that can aid us in identifying pain in these patients. On one hand, there are the smartwatches, the smart rings, or wristbands, which have sensors for different bodily functions, like the heart rate variability, our respiration, electrical skin response, skin temperature, or even movement. The belts that have been initially designed for fitness purposes may also have some electromyographic sensors that record the muscle activity. Let's now see what is happening in children. We well know that infants are unable to self-report their pain, and unfortunately it often goes under-recognized and under-treated. The application I have previously presented, Pain Check, has been validated and is used also in children, the Pain Check Infant Standard and adaptive modes, and it was proven they have high accuracy of predicting pain. The area under the curve is towards 1, so a good accuracy. An important aspect in infants is the post-surgical pain. there have been designed instruments that can help parents at home identify whether their children have pain in order to offer them either only feeding or feeding with the medication. They are using smart devices, so tablet or smartphone, on which they have Pain Check Infant application if they have iOS as operating system, or a similar application for Android with good results and good validity. There have been made studies on, there has been made meta-analysis regarding studies on children with postoperative pain. Unfortunately, it was quite difficult to compare the studies because there are many types of artificial intelligence models that were used, primarily deep learning and machine learning. The accuracy rates were not bad, ranging from 79 to 85%, and their predictability with area under the receiver operating characteristics between 84 and 94%. There still is required a multimodal, multicentric study to improve the performance of these tools. There have been developed also devices that are based on physiological signals for children, especially skin response that is particularly sensitive also in children to pain. And combining these skin sensors, signals, and machine learning, subjective pain experiences are transformed into quantifiable data. It was shown that these devices have high accuracy and real-time measurement capabilities. It seems very beautiful what the artificial intelligence is offering us, but as any technology has, it has also its limitations. Firstly, there still is a scarcity of comprehensive data sets. All the algorithms need large data sets in order to learn and become better in what they are doing, in setting etiology, in recording response to treatment. Given the fact that these technologies may not be widely available in all the world, there is this bias of selection. As we have only in certain populations access to these devices, our study will be made particularly on those populations. And therefore, there might be certain important ethnic groups that are excluded due to this inaccessibility. The input data must be also very specific. The models cannot generalize across significant differences in the patient population. So, for instance, a model that was trained on pain in individuals who have no movement limitations may not have a good predictive values in patients who suffered a stroke and currently have paralysis. Hence, it is vital that any model is not overgeneralized, but used for the specific situation it has been designed for. Of course, even well-trained artificial intelligence models can result in errors. Therefore, all their results or predictions should be interpreted in the clinical context and integrated in the decision by the physician and its team. There have been made studies also regarding the perception of caregivers about the use of such devices. Some of them exhibited worries regarding the accuracy of the data artificial intelligence devices offer. They were worried about over-reliance on technical data. They didn't want the clinical feeling to be overruled by what a machine was saying. Of course, privacy of the data was a concern and absent of a personal component. When it comes to assessing pain, judging the facial expressions, there were studies that showed that the landmark placement is less accurate when tested on the faces of individuals with dementia as compared to older adults who are cognitively healthy. We need to make algorithms specifically for this population to retrain and retune the methods that are already being used. We also need to see that as much as the artificial intelligence tries to surpass or at least approximate the human abilities in prediction and performance in diagnostics, the decisions still remain, as I said, made in a clinical team by the healthcare professionals. Unfortunately, it cannot yet determine causal relationships, at least not to that degree that would already help us in clinical settings. When it comes to the bioethical aspects, one of the most important aspects is regarding privacy, confidentiality, and informed consent, which need to be very well discussed when using these methods with the patient, with the caregivers. There are certain open questions that have been put. Is it ethical for a model to make a diagnosis completely autonomously? The robot or the artificial intelligence will never replace the clinical judgment. When it comes to the development of an artificial intelligence device or algorithm, there is involved a team that has both medical and non-medical professionals. The responsibility of the team is shared when it comes to using this device. It's not only the physician who uses it who is responsible for the use of the data, but also the one who develops, therefore the non-medical part of the team. The communication in this medical and non-medical team should remain not only in the development part of the product development, but also during all the process of using it. Generally, both caregivers, parents, and healthcare professionals were positive regarding the potential use of artificial intelligence method in neonatal intensive care units. But there were also identified certain worries, like regulations regarding the use. Each World Health Organization has set a legal frame for the use of these devices, but still it will take a time for these laws to be implemented in each particular country. Parents were also worried about their ability to choose whether this device will be used or not with their children. Therefore, in conclusion, artificial intelligence should be seen in its place as a complementary, very important part, especially in situations when communication is difficult. It helps us, but it doesn't replace us. The numerous algorithms still need to be trained. Further research is required. not forgetting the shared responsibility between all the members involved in the development of these devices, there still is something that is very profoundly human that artificial intelligence hasn't yet learned, which is empathy. What makes us profoundly human still remains only ours, and that is our soul. Thank you for your attention.